Tissue Integrity Part 3, Introduction to Nursing Concepts, Martha Olson. As we look at this wound, we can see then it's very open, it's got a lot of tissue damage, and it's going to take a long time for this one to heal. We need to first of all look at the factors that caused or influenced this wound, and then look at the factors that will influence the wound healing. It may be looking at dietary changes to add more protein in the diet. If it's circulatory problems, maybe we need to look at promoting circulation. So many factors go into getting this wound that we now have healed. The factors that are listed in the book are many. When we look at age, it can be things like circulation, oxygen to that wound. Do they have clotting or inflammatory issues? Do they have problems with impairment in the very old? We also have very young that are at high risk. So the risk of infection is greater. We know that cell growth and differentiation is slower as they get older. And age does affect all phases of that wound healing process. With the collagen that's deposited, it slows down also as a person ages. Looking at nutrition, we know a balanced diet is needed, especially the protein and the fluids in the diet. Cells need raw material from nutrients to contribute to that wound healing. The infection only prolongs that inflammatory response and delays the ability of collagen to be made and laid down into that, and with infection it prevents then the epithelialization of that tissue. The extra weight of obesity decreases the blood supply in the vessels because of that fatty tissue impairing the delivery of the nutrients and cellular elements that are needed then for healing. Wounds with extensive tissue loss are going to heal slower by secondary intention and will remain open longer and take longer to heal. So obviously a primary intention wound is going to heal quicker than that secondary. Tissue perfusion is getting oxygen down to that cellular level to repair. Chronic hypoxia, remember that's lack of oxygen, has been associated with impaired collagen synthesis and reduced tissue resistance to infection. Your smoker, as we've talked about, drops a lot of oxygen ability to exchange and causes vasoconstriction in the body. Immunosuppressant is anybody that has an inflammatory response from cortisone or being on steroid therapy. Anybody with an autoimmune disorder like lupus makes them more vulnerable to infection and slower healing. We've talked about Mrs. James with her diabetes, the small blood vessels, elevated blood glucose, risk for infection because of poor wound healing. They also have reduced collagen synthesis and wound strength as a result of being a diabetic. As far as radiation, we know that the tissue fibrosis and vascular scarring are part of radiation therapy. If we delay surgery more than 4 to 6 weeks, irradiated tissue then becomes very fragile and poorly perfused, and our wound stress is abdominal distension, more coughing that pulls at that wound edge and delays our tissue healing. Primary intention is good. The edges are tucked nicely together. We don't have a lot of tissue that's missing that has to be replaced or brought back in. And so on page 1181 in Potter and Perry, table 48.1 talks about primary intention. It's a clean surgical wound and our risk for infection is slight. Secondary intention is not as good. This is more of a severe laceration. When we look at examples of things that are secondary intention, we think of our decubiti or pressure ulcers, wounds that have a lot of loss of tissue. And so that laceration or pressure ulcer falls into that category. The edges don't close or fit nicely together, and they have an increased risk for infection in tissue. When I look at this patient not knowing what happened, I would guess that this surgical wound has to do with a lobectomy or removal of part of the lobe. That's a typical scar that we see with that type of surgery. Our delayed primary closure then, initially the surgical wound is initially closed in the deep tissue layers and we leave the subcu layers open. These are mostly the appendix that is ruptured is where I've seen this done, and that is because we have a drain into that area to drain that ruptured appendix, the fluid that's come from that appendix out, or a patient that had maybe a ruptured bowel. They leave the abdomen open to be able to drain the junk that's in there out. So the deep tissues are brought together. The wound heals by forming then that granulation tissue, and it's left open for a period of time. But as you're sitting here processing that, make sure you're thinking that that wound that's left open for several days is very high risk for infection. The wound heals with the layer of granulation tissue at the edge and at the base, and then they are brought together with sutures or adhesive closure. So up to 4 days, sometimes we can leave a tissue open, and later on I will show you what a Penrose drain is that would be put into that open appendix area to drain that. Our granulation tissue picture then is characterized by that pinkish red tissue with multiple capillaries. So you can see how bright red it is, meaning there's blood flow and good stuff to that. The black necrotic tissue needs to come out of this wound so that that red granulation tissue can start the healing process. We will be talking about debridement as a form of cleansing. We're going to talk about why the moist environment is very necessary for proper wound healing, because your wound will not heal in a dry environment. And then we're going to look at how we can prevent further injury and promote healing in that. With our debridement, you will be doing that back in the lab. That is your wound and skin tissue, where we look at debriding the wound with a sterile dressing. We take out the non-viable or the dead tissue that's there, and then with the process of doing that, it takes out the foreign debris that is in that area. On page 1199, the 4 different types of debridement we will be talking about. Mechanical is that wet to dry saline gauze that you will be doing in the lab. We also will talk about autolytic, chemical, and then our surgical or sharp. In looking at this necrotic tissue, that needs to be debrided out of there. So the surgeon or the doctor, woundostomy nurse, will decide what type of debridement will be needed. In looking at this one, we see the slough tissue that's in the middle, that whitish with the red capillaries to the side. Our autolytic debridement then is a wrap that's put on that has chemicals. It just kind of digests slowly. The body's enzymes soften and liquefy to allow that area that's dead to be able to loosen and be able to be pulled off very easily. We want to keep the wound moist. It also then helps prevent infection to that area. So that transparent film or dressing is often known as a hydrocolloid dressing over that. Biochemical means we put the enzymes directly into that dead or that non-viable necrotic tissue. It's allowed to remain on and kind of work its way in to soften or loosen that area of necrosis. A lace is the example that is most often used, or granulex is the other one that we might see. Mechanical debridement, what you will be doing, this is your wet to dry. When you get your saline and you get your gauze wet, wring it out, because you don't want to put it in dripping wet, but you want it a nice moist to go into that wound bed. It's allowed to dry, and then when you remove the dressing, you can see the yellow that's on there. That is a way of debriding that necrotic tissue by pulling it off. You don't want to jerk it or pull it so that you're taking the healthy tissue underneath that's trying to grow, but you also want to be able to pull a little bit of that tissue off. In the wet to dry dressing, then remember, it's packed with that moist gauze. That will all be done sterilely, and as you have the Q-tip and you're putting your sterile moist gauze in there, need to look for any tunneling or little pockets in that area that have been missed, because the gauze needs to go down into those as well. We usually leave that in about 4 to 6 hours, and it should have dried and stuck or adhered to that tissue. We do not want to moisten it to remove it, or the process of debridement will not take place. When we pack a wound, then, as you can see in the picture, you have to go down into the center of the wound so that that sterile gauze is not allowed to touch that skin surrounding the area, or you will be introducing microorganisms into that. As you look at that bottom picture, you can see that the dressing is then flat with the skin. You'd put a covered dressing over that. You don't want it heaping above. You don't want it sunk down in below. we are not to pack it too tightly, because overpacking then would cause pressure on that tissue in the wound bed. It's kind of like overpacking your suitcase and then the zipper breaks. So you want to put that tissue in there nicely and kind of tap it down, but not too hard. We just want it to be sitting in there nicely, helping that wound bed to remain moist and to debride. So the moist environment promotes healing, and as you read on page 1199 and 1200, moisture supports the movement of epithelial cells. Epithelial cells want to move to an area where there's something to drink, and so it promotes the healthy, nice tissue cells to come in and help close that wound up. Excessive moisture would be bad because it would start then to support bacterial growth, and your tissue bed would then become wet and boggy, kind of macerated, and slow the healing process down. So it's kind of a trick to have it moist but not soaking wet or damp. You should never be dripping from your dressing or your gauze into that wound bed. Do we need to add a drain? If there's excessive moisture in there, perhaps a JP or a different type of drain would be necessary for that. The wound will not heal unless the contributory factors are controlled or eliminated. Potter and Perry on 1199 states nursing needs to address these causative factors. If it's moisture to the skin, do we need to look at a TENS, changing linen more often? If it's a pressure issue, do we need to reposition or look at use of pillows or a special bed for them as a result? Sharp debridement is one that I don't see used a lot, but the surgeon would take them back into surgery or at least perform it in a sterile manner in a controlled environment using a sharp scalpel, then to take that necrotic tissue and cut it out of there without damaging the tissue down below it. And then here is the next step of that debridement, where they're pulling that, looking at that red tissue underneath with blood cells to support the growth of that. So in summary of this third PowerPoint that we've looked at, our healing process is going to be a lot of nursing judgment as to how we want to try to reposition, encourage nutrition. We looked at primary versus secondary intention, with primary being the nice surgical wound that's closed, and your secondary is much harder to heal, and that's where we get into then debriding and treating of that wound in the best possible way for that patient. Our 4 types of debridement finished up this PowerPoint slide then, as we looked at the autolytic, the wet to dry that nursing will be doing in the lab. Our mechanical is things such as a lace, and then our last one is the surgical debridement of that wound. Thank you.